Then Nikita Sharma, she will be presenting on the ossified choroid.
Good evening, everyone. So, as for introduction of choroidal osteoma is a rare benign ossifying tumor of the choroid of unknown etiology and is an unusual form of intraocular ossification. First described by Gass in 1978, the predominantly occurs in healthy young females in second or third decade of life and located in juxtapapillary or peripapillary area and is mostly unilateral. Usually asymptomatic but may present with mild or severe blurring of vision, metamorphopsia and visual defects. Although it has characteristic clinical fundus pictures, B-scan, OCT and fundus fluorescein angiography, findings are diagnostic to differentiate. Our case was a 16-year-old girl which presented to us for blurring of vision in left eye for 1 year. She had no other ocular complaints, no history of ocular trauma or symptoms suggestive of any past intraocular inflammation. She had a history of right-sided pleural effusion with pneumonia with severe anemia 6 months back, for which she had been treated and given a blood transfusion to correct the anemia. She is also a known case of moderate mitral regurgitation, which are all incidental findings. No similar complaints in any other family member or general examination were unremarkable. Her ocular examination was best corrected visual acuity in right eye was -0.5 with -0.5 cylinder at 30 degree was 6/6 and at 90 degree -0.5 was 6/9. Near vision was normal, NCT was within normal limits, color vision and color contrast were decreased, pupillary reaction and slit lamp examination all were normal, within normal limits. Fundus examination of the right eye was normal and left eye showed clear media with normal disc and an orange colored choroidal lesion with well-defined borders with molted depigmentation of overlying RP over the posterior pole involving macula. The central area of blackening likely corresponds to decalcification of choroidal osteoma. FFA of left eye shows central hypofluorescence with surrounding speckled hyperfluorescence in the area of chronic RP decompensation. The central hypofluorescence likely corresponds to the deossified area of choroidal osteoma with atrophy of RP and choroid. Late diffuse staining was noted. On OCT of left eye, concavity of retinal contour involving foveal area, hyperreflective lesion with lamellar pattern noticed with overlying disorganization of outer retina or RP. Undulations in the lesions were noted due to formation of reabsorption base suggestive of deossifying nature of the choroidal osteoma. B-scan showed a slightly elevated hyperechoic choroidal mass with acoustic shadowing giving a pseudo-optic disc appearance as seen on B-scan, and A-scan showed high spike intensity spike. Perimetry, there was a field effect corresponding to the area of our defect. In literature, the largest case series included 61 patients over a period of 26 years of ocular oncology practice in major tertiary care center. Exact etiology remains unknown, but few theories on its origin includes congenital causes, osseous choriostoma, inflammatory conditions, and endocrine disorders. Clinically, it is a unilateral located in peripapillary and juxtapapillary area and may extend to macula. It is oval to round in shape with scalloped or geographical borders with overlying blood vessels ranging from 2 to 22 mm in size and 0.5 to 2.5 mm in elevation. It appears yellow-white to orange-red depending on the thickening and thinning and depigmentation of the overlying retinal pigment epithelium. Histopathologically, choroid is replaced with mature cancellous bones with dense trabeculae and endothelial lined large cavernous spaces and small capillary blood vessels. No hematopoietic activity is seen. CNVM and subretinal fluids, hemorrhages, and serious retinal detachments are important complications which were not present in our case. Our patient diagnosis was made basically on the characteristic clinical and ultrasonic pictures and fundus fluorescein angiography. Till now, it's been 9 months post diagnosis, and the patient is still stable with the same refractive power.
What are the main differential diagnoses whenever you come across such cases? And though it is a rare presentation that the calcification in the choroid or the choroidal osteoma. So what are the main differential diagnoses commonly mimic like this, and you may confuse and you may miss if at all if this patient comes to you?
So metastatic cancers, melanomas.
ostiomas will be a different entity, and the diagnosis criteria is different as compared to the choroidal ostiomas. Yeah. Okay, the complications you have narrated that that may give rise to the
CNVM.
yeah,
and,
CNVM, hemorrhages and all those
Yes,
things.
sir.
Yeah. So what is the definitive treatment for this? If at all, if you diagnose this and now you want to treat the condition, so which is the main or the easiest modality by which you can treat such conditions?
So if it develops CNVM or a bleed, we have to give anti-VGFs.
So till that CNVM and bleed doesn't come, you will not treat the condition? That is a treatment of complication, but per se if you see the condition like this, you have to treat it, no? You have to think of some differential diagnosis, then of course the investigations and all also you have to plan, and you have to treat it so that the complication should not develop. So early treatment will prevent the occurrence of the complications. Anyway, okay.
Thank you.
Sir, you want to ask something? Dr. Vishal wants to ask. Okay.